इससे next slide. ठीक है. Assalamu alaikum. Let's start the lecture today. Today we are going to discuss a very important topic, and that is fever without a source and fever with rash. The objectives for today's session will be that at the end of the session, the participants should be able to know and differentiate the most common causes of fever without localizing signs, should be able to identify various types of rashes that present with fever, and know importance of history taking, physical examination and laboratory workup in the evaluation of a patient with fever. And identify red flags or danger signs in patients who presents with fever, and know indications when to refer patient to the specialist or a tertiary care hospital. First question, why is this topic important? It is important both for your practice as well as for MRCGP. For the practice, it's the most common mode of presentation in OPD clinics, in emergency, to general practitioners or even specialists. And correct diagnosis is very important, as timely diagnosis and in reducing the morbidity and mortality. In MRCGP, especially for the Asian countries, in our region, infectious diseases are very prevalent. So there is a lot of stress on infectious diseases. Okay, let's start by discussing a case. This is a tough case, and let's get your opinion what you are going to do if such a patient comes to your office. A 22-year-old medical student without significant past medical history comes to OPD for fever of 101 degree Fahrenheit, which occurred this morning. She feels a little lethargic but denies any specific symptoms, and physical examination is unremarkable, and temperature you did in the office, and it is 98 degree Fahrenheit. So what's the next step in evaluation of this patient? Complete history, no localizing signs. She just feels a little lethargic, but there are no other symptoms that could point to a diagnosis. It was just one spike. She noticed 101, but otherwise she has been fine. And examination, complete examination, you took 15 minutes and everything is fine. No significant past medical history, no other epidemiological clues, no travel, no surgery, no trauma. She feels fine. No history of flu, no history of any illness in her contacts at home. Yes. The question is what you are going to do. Are you going to investigate this patient? Are you going to start empirically any medications or antibiotics in this patient? Yeah. At least for 2-3 days. Ask her to come again next time. Right. So she's a healthy lady, immunocompetent, no significant risk factors, and she comes to you with the first symptom. So she is very educated and she's concerned about her health. So even if you send her home, she's going to come back if her symptoms doesn't get better or even get worse. So you are assured here that she is not going to be non-compliant, and you don't find anything. So there are two approaches. One approach is to evaluate, do the lab work, start antibiotics and send her home. The other is to wait. And usually most of the people, they prefer to wait, because most of the fever in healthy young people, they settle by themselves. They are usually viral or some fatigue or something else. So in this patient, if you reassure her, reassuring is very important, that this is the start of the illness, it may go away, and most of the fevers, they resolve on their own. And I'm not going to do anything, we won't start any treatment. But if your fever continues or you develop new symptoms, you come back, we'll identify the disease and we'll give you the specific treatment. So reassuring her, educating her is very important, right? Okay, let's go to other case. This is a 30-year-old male who underwent right lung lobectomy for a refractory hydrated cyst, in May 2006. Received 2 transfusions during the surgery, and post-operative course was benign, and after a week he was discharged home. So 2 weeks later he started having fevers for the past 1 week, and after a week he comes to you complaining that for the past 1 week he's having fever ranging 101 to 102. So what you are going to do with it? What do you think is going on with this patient? Malaria. Someone said malaria. Why is that? Blood transfusion. Blood transfusion is risk factor for malaria. Yeah. So you will also consider that she has a surgery. So after surgery, does she have any collection in the chest? At the surgery, she was intubated. She must have a Foley's catheter in. She must have IV lines in. So any infection, any UTI, or anything happened during surgery, and she is coming as a complication now. So you will consider all those factors. You take a history, and patient says that there are chills, headache, and does have a dry cough, but no phlegm, and complains of weakness, myalgias, but on further questioning, no abdominal symptoms, no diarrhea, constipation, and no arthralgias. So what do you think? Does this narrow down our differential diagnosis? So these symptoms are non-specific. If you just chills, headache, dry cough, weakness, myalgias, they are not pointing to a specific region where the fever is coming from. Had this been that he was having a productive cough or pleuritic chest pain or shortness of breath, you must be thinking something is going on in his chest. But these symptoms are very non-specific. So you the respiratory causes, especially the upper respiratory. Does have a dry cough, you should never know what's going on in his chest. So definitely you would like to rule that out. So you proceed to the examination. Blood pressure is 100 by 65, pulse is 80 per minute, respiration is 14 per minute, temperature is 99, and wound is clean and dry, chest is clear on auscultation, and the complete examination is unremarkable. So after this examination, probably the complication in chest is less likely, but the UTI is still there, though the patient is not saying that he's having any dysuria or anything. So we'd like to go with the investigation. So this patient had a CBC, hemoglobin 10.4, WBC 2.5, 80% polymorphonuclear cells, 6% bands, 12% lymphocytes, eosinophils 1%, and platelets are 130. So what do you think about this blood picture? Leukopenia, right. So this patient is having leukopenia. What does that tell us? Is this a bacterial process or it's a non-bacterial process? Okay, it's a non-bacterial. So what about PMNs and bands? Is this a left shift? Yes, this is a left shift. So in septicemia or bacteremias, the white cell count can go either way. It can be leukocytosis or it can be leukopenia. And the difference is that in leukopenia, the shift will be to the left. You can see bands and premature forms, right? But platelets are also 130, right? So this patient has leukopenia, thrombocytopenia, and slight left shift. But the patient's clinical picture doesn't go with a severe sepsis. His symptoms are non-specific. He doesn't look that toxic. Blood pressure is fine. He's not that tachycardic. Respiratory rate is fine. So he doesn't go with severe sepsis.
Pulse is not corresponding with the temperature, and there is leukopenia. It also favors enteric.
True. Relative bradycardia is a non-specific thing. It was correlated with enteric fever, but they say now that you have to go with the whole picture. Instead of you find a bradycardia, you say this is enteric, but you have to find the other symptom complex. LFTs, ALT 30, AST is 24, bilirubin 1.6, ALK-Phos is normal, and LDH is 882, which is raised. So what does this tell us? Bilirubin is slightly raised, right? LDH is high, so it could be intravascular hemolysis, and this LDH is coming from red cells, right? So leukopenia, thrombocytopenia, slightly high bilirubin, increase in LDH, more goes with malaria. Chest X-ray you did find no infiltrate and no change from the previous X-ray. ESR is 35, and you order malarial parasite film, and as always it has come back negative twice. You do a Widal test, which is negative, blood cultures are negative. So what's the diagnosis? Most probably malaria, right. This patient was given a trial of chloroquine and fever settled within 48 hours. So if you look at this picture, fevers with non-specific sign symptoms and anemia, thrombocytopenia, slightly high bilirubin, increased LDH, and settled with the trial of anti-malarial drugs. MP slide is very dependent on the operator. So in our labs, we know that our technicians are really undergoing a heavy burden. I mean, they don't have time to look at the malarial film, which they should. So that's why usually they are falsely negative. Let's take another case. It's a 40-year-old villager who comes to you for fever of 6 weeks duration. Fever is associated with rigors and chills, and he complains of headache, myalgias, anorexia, sweating, and weight loss of 2 kg over the previous 6 weeks. For the last 3 weeks, he also complained of bad taste in his mouth. So what do you think about this patient? क्या हो सकता है? राइस मैक्सिमम कितना जाता है?
ये इंडिकेट करते हैं बैड टेस्ट एंड माउथ जो है दैट इंडिकेट सम लिवर could be because
liver pathology, it could be usually severe anorexia in hepatitis, but his picture is going on for the past 6 weeks, so we'll see on examination in labs what's going on. But what do you think about this rigors and chills? Could it be malaria? It could be. Okay, rigors and chills, aren't they specific for malaria? So any fever can cause chills, right? And the rigors, what's the difference between rigors and chills? Severe shivering is rigors, and they usually signify bacteremia or parasitemia. Okay. On further questioning, he admits that he is little depressed, and he has changed 4 physicians in the past 4 weeks. So here you are on a trial again. He has been treated with ciprofloxacin, cefixime, the 3rd generation cephalosporin, Artem, halofentrin, and IV ceftriaxone, but his fever has not responded. So what does that tell you? Liver abscess. So it means that either the organism is not sensitive to these drugs, or this patient has a focus of infection where antibiotics are not penetrating, like abscesses, right? Or the organism is resistant to these.
Or he has not applied properly, or he has taken dosages, not taken adequate dose and for adequate.
That's a possibility. Here the dosages are not mentioned, so we don't know.
Adequate duration.
Okay, but let me tell you that dosages were adequate. Right, liver abscess is high on the differential.
even anywhere in the body, even in the peritonitis, abscess or some chronic abscess, then can give us.
Right. Okay, let's go to the physical exam then. It's not low grade. The fever, he says, is 102, 103. Okay, you do a detailed history and you don't find any clue except that he owns a cow and has drank unpasteurized milk off and on. Tuberculosis? Brucellosis. Anything else? Okay, you decide to do a workup. That included CBC, malarial parasite film, blood cultures, urine RE cultures, LFTs, BU and creatinine, and they were all normal. You do an ultrasound to rule out hepatic abscess. That showed mild hepatosplenomegaly, but no abscess. ESR is 60, chest X-ray is clear. So, what you are going to do now? So you said tuberculosis, brucellosis. Could it be a viral infection? Why no?
Not for that long.
Right. 4 weeks, yeah. If the fever goes more than 4 weeks, then usually, not always, the viral infections are out. But sometimes CMV, Epstein-Barr viruses, they can cause a prolonged course, and more commonly in immunocompromised people. So viruses are probably out. And malarial treatment he has taken, and he has been treated for typhoid. Blood cultures are negative, so probably they are not high on the list. So tuberculosis or brucellosis. So Mycobacterium bovis from cattle, that can cause intestinal TB, but he doesn't have any symptoms of gastrointestinal TB. So you decide to do right, but it can be high grade. We have seen 103 with chills in tuberculosis. Resistant malaria, right. But for the past 6 weeks, he doesn't have thrombocytopenia, no anemia, no other, laboratory tests that could. And he has taken, right. So serology for Brucella abortus comes back positive, titer of 1:160. Is this positive or negative?
It is positive.
It is positive. 1:160 or above is positive. So this patient was put on Brucella treatment and his fever resolved gradually over the 7 days. Okay, case 4. 55-year-old female with past medical history of hypertension, diabetes type 2 and cholelithiasis presents to you with fever and chills of 3 weeks duration. She has seen an internist who has ordered a Widol test that was positive in a titer of 1:160. And he put her on ofloxacin 400 BD without any improvement. So what do you think? Does this patient has typhoid fever? Why? She has a positive Widol.
Should have treated
the antigen is A or O and it is positive in the ratio of 160, then it will be considered as positive. Otherwise, because she is already in the 3rd week, it must have gone up already.
She must be more.
करते हैं फिर हमने राइजिंग टाइटर देखना है कि टाइटर जो है वो इंक्रीज हो रहा है.
Right.
अगर उसकी एंटीजन A है या O है और वो 160 में पॉजिटिव है, that will be classified as Widol positive.
Yes, and here we don't know what was her baseline titer. It may be 1:20 to start with, so it's a 4-fold rise in that case. But anyway, so alone on Widol test, you cannot label this patient having enteric fever, right? You have to go with the symptom complex. So let's proceed. You order a repeat workup, CBC, LFTs, urine RE, creatinine, chest X-ray, all normal. Except hemoglobin is 10, platelets 350 and ALT is 60. So ALT is slightly raised, right? So we don't know her baseline ALT. She might be having fatty liver, she might be having chronic hepatitis C or something affecting her reticuloendothelial system. You do an ultrasound and this time it reveals an abscess. right? So if fever is not responding to antibiotics, you have to do the workup and you think in these terms. Is this a wrong diagnosis? Is this bacteria which we are treating is resistant? Or is this an infection where antibiotics are not penetrating? So as a rule, pus should be drained, right? So that's why ofloxacin, though does cover gram negatives, but this patient has not responded and we don't know the etiology of the abscess. Pregnant gynecologist comes to you for fever of 2 weeks duration, complains of fever of 101 degree every day, and she has marked weakness, poor weight gain, and further questioning she admits that she has severe anorexia, sweats and mild dysuria, but no urgency and frequency. And her husband, who is a doctor, is also accompanying her, and both of them look very worried. So what's the differential here? It's broad, right? She's having fever for the past 2 weeks. So it could be typhoid, malaria, brucella, TB, or some deep abscesses, or some other infections, occult infections, right? So you proceed, and she says that she was self-treated with cefixime and chloroquine, but did not show any improvement. And you review her investigation file, and everything was normal except hemoglobin was 8, she was anemic, WBC 3.2, leukopenic, without left shift, platelets slightly high, 495, ESR is 90, and urine RE shows 15 to 20 pus cells, but the cultures were negative. So what do you think about this picture? UTI, she has pus cells. So, but the cultures are negative.
Because she was taking all the antibiotics.
That could be the reason. But this urine was taken before she took the antibiotics.
But it could be because of tuberculosis. Sometimes tuberculosis of the genital tract that gives rise to the pus cells, but they are otherwise culture negative.
But her chest X-ray is normal.
Even the patient can have secondary tuberculosis.
Right. So patient can have extrapulmonary tuberculosis, and that's really a diagnostic dilemma, because chest X-ray it's more evident. But if it's extrapulmonary and she doesn't have symptoms, so that's very hard to diagnose. So this may be a clue. Is this genitourinary tuberculosis? Possible.
इसमें ये कल्चर की रिपोर्ट जो है we have to suspect that report also. We should do it twice.
Right. Okay, so you repeated all investigations which were done 10 days ago. And this was a chest X-ray. 10 days ago it was normal. And now the chest X-ray shows miliary pattern, maybe not very evident on the screen, but you can see that there are diffuse small millet-like patterns bilaterally. So the quality of the film is not that great, pardon me, but this was a picture that 10 days ago her X-ray was normal, and after 10 days her chest X-ray is showing miliary pattern. So most likely she might be having a genitourinary TB, and that has disseminated. And usually, what are the risk factors that predispose to dissemination? Immunocompromised states, steroids, chemotherapy, diabetes, uremia, and pregnancy, right? Okay, this is a diagram showing millet seeds with a scale that how small they are. Okay, last case. 16-year-old boy presents to you with fever for 1 week. Fever spikes 103, 104 degree Fahrenheit with chills. He feels exhausted and complain of headache, dry cough, and mild abdominal distension. And you look at him and he looks a little toxic. What do you think he's having? Enteric. That's the only disease left, I guess. Okay, on exam, his temperature is 103 degree Fahrenheit, pulse is 90 per minute, blood pressure 110 by 70, respiration is 20 per minute. Respiratory rate is a little high, and patient is having relative bradycardia. His tongue is white coated, chest is clear, and abdomen is non-tender and non-distended. So what's the diagnosis? Typhoid is most likely, right? You do a lab, almost leukopenia without a left shift, platelets are normal, LFT slight rise in ALT, and LDH, alk-phos are normal, and Vidal is 1:160. So if you put the whole picture together, it more goes with typhoid. And the blood culture which was sent.
ALT is rising typhoid?
Yes, typhoid can cause hepatomegaly, it can cause mild rise in transaminase levels. And the blood cultures come back growing Salmonella typhi. Okay, these were the cases showing that fever without source. So fever without source mean that symptoms are non-specific. They are not pointing towards a diagnosis. If a patient comes to fever, pharyngitis, probably it's a sore throat. It's straightforward. But if it comes with fever, non-specific signs, then all these are in the differential diagnosis, plus some other, which I'm going to show you in a chart. And these are this is a chart showing bacterial, viral, and parasitic causes. These are the most common causes. The list is really exhaustive. And you have to remember, most important thing is just sepsis. Sometimes intra-abdominal source, patient might be having diverticulitis and he's having gram-negative bacteremia from there. So you have to really look for the signs of sepsis. What's the blood pressure? Does the patient look very toxic? Is he in respiratory distress? And other diseases discussed: typhoid, brucella, TB, and subacute bacterial endocarditis. Usually it comes with fever, and usually it's listed as a cause of PUO. Osteomyelitis, deep visceral abscesses, acute hepatitis in early stages without localizing, just vomiting, nausea, fever, myalgias, headaches. And in viral causes, influenza, dengue fever. Dengue fever is common, especially in Karachi. Cytomegalovirus, Epstein-Barr virus, echovirus is more common in summer season. And protozoal malaria, amoebiasis, babesiosis. Okay, so take-home lesson from this is that the danger signs are really important. Hypotension, respiratory distress, altered mental status, signs of meningeal irritation, neck stiffness, toxic appearance, bleeding tendency, patient is having hematemesis, bleeding in the urine, epistaxis, hemoptysis. You really have to think about, is this patient having DIC, is this having viral hemorrhagic fever, things like that. Okay, fever with rash. Let's go through that quickly. Fever with rash is very important because it could be life-threatening. You might be facing with infection control issues. For example, viral hemorrhagic fevers, it could be an outbreak. So you have to be very diligent in taking history, physical exam, and the lab work. And these are the epidemiological clues that might help. For example, some diseases are common in childhood, like viral exanthems, measles, rubella, etc. Season of the year, some diseases are common more in winter, like meningococcemia, parvovirus. Some infections are more common in summer, like enteroviruses. Measles, rubella more in spring season. Travel history, geographically diseases, they are endemic. Immunization history is very important, and exposures to ill contacts, insect bites, animals, like a case in which the villager owned a cow and he was drinking unpasteurized milk. So history of that contact is important. Medication, is this rash secondary to medications? And the immune status of the patient, because immunocompromised patients, in them the infection could be very rapidly fatal, and their ecological agents also differ. Okay. History taking of a rash, that is important, and the first thing is to characterize the lesion, which we are going to discuss. Is it a macule, is it a papule, is it a blister, is it a vesicle, is it a pustule, and where it is distributed, regions of the body it is affecting, and progression of the rash, how it spreads. Centrifugal, centripetal. Rash spreads from center and goes to the periphery. This is centrifugal, and from periphery to the center it's centripetal. Timing of the onset in relation to fever. For example, if someone has not taken a medication and his rash has appeared, so you cannot label that rash as a drug rash. Progression of the lesions. Macules sometimes progress to papules and vesicles and then petechiae. And was a prodrome present, as is more common with viral exanthems? This is a diagram showing a macule, which is a flat discoloration of the skin. It's not raised and less than 0.5 centimeter. This is a papule, which is a raised solid lesion less than 0.5 centimeter. This is a nodule, which is a deep rounded solid mass less than 1.5 centimeter. This is a pustule showing a pus. The skin is raised, filled with fluid and pus. And this is a vesicle, raised skin filled with fluid. Okay, here is a term ananthem. What does that mean? The other word I used was exanthem, right? Exanthem is when the lesions occur on the skin. For example, in measles, it's a maculopapular rash on the skin. So that's an exanthem. Ananthem is when the lesion affects the mucous membranes. So these are the diagrams showing. This is a conjunctivitis. This is a red strawberry tongue in scarlet fever or Kawasaki syndrome. And these are the complex spots, whitish spots near to the upper second molar, characteristic of measles. And these are the palatal petechiae, more common in infectious mononucleosis. Physical examination is very important. Vital signs, very critical. General appearance is the most important thing. Studies have shown that the physician impression, how does the patient look? If just by looking at the patient, this patient doesn't look good, 99.9% of the time you are right. Signs of meningeal irritation, complete neurological evaluation, liver spleen size, joint examinations, detailed skin examination. Laboratory testing, routine CBC, blood culture, serological tests, fluids from the skin lesion is very important, both for the culture, staining for gram stain, and sometimes Zank smear, which is characteristic for herpes viruses, and dark field microscopy, especially in patients with syphilis, and biopsy and for histopathology. Epidemiological clues, first is age, and these are the diseases which commonly present in childhood. So if a adult patient comes to you with maculopapular rash, these are less likely, though not impossible. What is this? Yes, this is brick red erythematous maculopapular rash starting from the face and then spreading to the periphery. And you can see this patient also having conjunctivitis. This is the rash at the trunk, same rash. This is a conjunctivitis, and these are the complex spots we saw. Okay, the most important thing in fever with rash is sequence of the rash to the fever. So here is measles algorithm, and you can see that here the patient started having temperature, and you can see at the same time patient has conjunctivitis, coryza, runny nose, and cough. And after 3-4 days the typical exanthem appears, and after 4-5 days then it starts fading away. What is this? This is a fine red maculopapular rash, not morbilliform as compared to the measles, and this is German measles or rubella, and this disease is more benign. What is this? Chicken pox, and you can see that these lesions are very specific. In one field you can see all sorts of lesions. You can see macules, you can see papules, you can see pustules, you can see vesicles and crusted lesions. So in just one square you can see all sorts of lesions, and this is very typical for chicken pox. What is this? Parvovirus. This is called slapped cheek appearance. This is how the rash starts. And after this, you can see a net-like or lace-like rash spreading all over the body. And here is a sequence of events. First, the rash appears, the cheek becomes red, and after 2 days, the exanthem, the net-like or lace-like pattern starts. And the parvovirus IgM are positive even in the incubation period. What is this? Roseola infantum. This is a childhood disease by human herpes virus 6. And this is very typical. The clinical diagnosis is very accurate. And the reason is that patient starts having temperature, and as after 3-4 days the temperature resolves, and as the patient become afebrile, either the patient will have a seizure and then develop an exanthem, so no fever after that. So this is very typical. Fever resolves and then the rash appears. Okay, this is maculopapular rash, and this is infectious mononucleosis. And this is the flow diagram showing here the patient is having fever, non-specific symptoms, headache and malaise, develops sore throat, tonsillitis, and then after 3-4-5 days develops an exanthem, maculopapular rash. Again starts from the center and goes to the periphery. Important thing is that the monospot test or heterophil antibodies don't become positive until 7 days. So if you do this test here, it's going to be negative. So the test you can do if you want to really confirm is capsid antigen, IgG and IgM2 viral capsid antigens. What is this? Pharyngitis along with palatal petechiae, more common in infectious mononucleosis. What is this? Okay, we saw that the rash could be papule, macule, maculopapular, vesicular, and the other thing is it could be diffuse erythematous. So there are 2-3 things which cause diffuse erythema, which we'll discuss later, and this is more common in scarlet fever and toxic shock syndrome. So this is the case of scarlet fever. Scarlet fever is also characterized by an ananthem, which is a strawberry red tongue, and this is the flow diagram. Patient spikes temperature, develops pharyngitis, non-specific symptoms, white coated tongue, strawberry tongue, and here after 2-3 days the exanthem starts. And then it resolves by desquamation. Okay, what is this? This is erythema marginatum, and this is characteristic of which disease? Acute rheumatic fever. Looks like tinea, but they are multiple. But if you look at the symptom complex, not just by looking at it, this is characteristic of acute rheumatic fever. And this patient has subcutaneous nodules. So in Jones criteria, if you remember, there are 5 major criteria: carditis, arthritis, subcutaneous nodules, erythema marginatum, and chorea. Okay, what is this? What type of lesion is this? Macule, papule, vesicle, pustule. Pustule. So these pustules could be either disseminated herpes infection, immunocompromised. It could be disseminated gonococcemia, or it could be hand, foot and mouth disease, which is an echovirus. But this is a picture of a patient who is having disseminated gonococcemia.
Infection, scabies, super infection in scabies.
In scabies, right. Bioscabies, yeah, but this is not a typical location. So, I mean, you cannot diagnose just by looking at one thing. You have to look at the constellation of symptoms and signs. Okay, what is this? Macule, papule, vesicle, pustule. This is more like a macule, and these are the point lesions of secondary syphilis. So the point I'm trying to make is that the sexual history is very important, and you may cross people who are having secondary or tertiary syphilis and disseminated gonococcemia. The other thing important I have included in the slide is acute retroviral syndrome. That is when a person acquires an acute HIV infection. And the acute retroviral syndrome resembles like infectious mononucleosis. Fever, sore throat, maculopapular rash, lymphadenopathy. So you have to take a sexual history, and if it's is at high risk, then you have to do HIV screening. Then there are other skin conditions which are caused by multiple infectious and non-infectious etiologies like erythema multiforme, erythema nodosum, and toxic epidermal necrolysis. These are the examples. I'm not going to go in detail. You will get the handouts that what type of lesions are there and what are the causes. And these are the most common causes I have encircled here. And these are the fungal and the viral causes. And these are the protozoal, parasitic and non-infectious causes. Don't forget non-infectious causes of fever. As you can see that erythema multiforme, SLE, drug-induced hypersensitivities, they can also cause the same fever and rash. This is an example of erythema multiforme or the target cells. The most common cause of this is sulfonamides. Patient receives Septron and after 2-3 days he developed this lesion. This is erythema nodosum, the painful nodules over the shin, and these are more common in tuberculosis, sarcoidosis, Behçet's disease, and streptococcal infections. This is toxic epidermal necrolysis secondary to drugs, and the skin becomes very painful initially and red, and then the skin peels off. And these are the causes of erythema multiforme. You can go in detail later. And these are for the toxic epidermal necrolysis. So this is just for your reference. You don't have to remember all these things. Okay, the last thing is you have to really know what are the emergencies. And these are the 4 emergencies when patient presents with fever and rash. Meningococcemia, patient presents to you with fever in the morning and he might be dead by late afternoon. So it's very important. Bacterial endocarditis, patient might lose his valve. Rocky Mountain spotted fever is more common in Oklahoma states, in USA, but we don't have any data or statistics here. And toxic shock syndromes, more commonly either streptococcal or staphylococcal. These are the subconjunctival embolic phenomena in a patient with endocarditis. And these are the red, non-tender, blanchable lesions which are called Janeway's lesions. So if you are suspecting a patient with endocarditis, you have to look for all these signs. These are the splinter hemorrhages. They could be traumatic, but you have to see them by putting the whole picture of the patient. And these are the ossular nodes, violaceous red tender nodes at the pulp, in the pulp of the fingers. What is this? This is called purpura fulminans, more characteristic of severe meningococcemia. And you can see that purpuric lesions, and they are going to develop bullae and hemorrhages. This is a diffuse erythroderma in a patient with toxic shock syndrome. And toxic shock syndrome patients also have conjunctival suffusions. And after their rash, then it desquamates. Though this is a picture of scarlet fever, but desquamation is also a characteristic of toxic shock syndrome. I'm going to end here. Thank you for your attention, and feel free to ask any questions.